Live? Good evening. Dr. Oz, I'm an anesthesiologist at JLR Medical Group at Florida Hospital. We are Florida Hospital's Department of Anesthesiology. I serve as the medical director for liver transplant anesthesiology, and privileged to have a collaborative presentation today on behalf of Florida Hospital, the Central Florida Point of Care Network, and ROTEM, the manufacturers behind Thromboelastometry. Our presenter today is Dr. Klaus Gorlinger, who's here from University Hospital in Essen, Germany, who's going to be speaking about Thromboelastometry's role in bleeding management for major surgery. His main area of research is perioperative hemostasis, and he's published over 30 papers on the effects of trauma, hepatic disorders, therapeutics related to blood management. I had the privilege of hearing Dr. Gerlinger speak at the International Liver Transplant Society meeting a few years ago, and that sparked our tremendous interest in the device and its utility in our liver transplant program here. He has published papers and presented with the European Society of Anesthesiology, Transfusion and Hemostasis Committees, the Task Force on Severe Bleeding Management, and presented at the American Society of Anesthesiology, as well as the Liver Intensive Care Group of Europe, both in Vienna and Pisa. Without further ado, Dr. Gerlinger.
This is Becky Williams from the IT team at Florida Hospital. We are going to reserve some time at the end for questions and answers. For those of you on the phone, could you please be kind and mute the phone? Towards the end, we will open that up and take your phone or take your questions via phone. For those of you on the internet joining us from the live meeting, you should see a Q&A tab at the very top of your meeting window. You can type in questions there, and we will reserve them till the end. Thank you.
Becky, questions. I'm seeing a message. Thank you for inviting me and talking about our experience in using thromboelastometry in bleeding management in major surgery. Oh.
That doesn't work. Try to go to the next slide. Sorry, that doesn't work.
Can anybody hear me?
Wow. Now it works.
Sorry.
That's on my conflict of interest that I get the speakers honoraria from TEM International, Verum Diagnostica, Caesar Behring, and Octa Farm. And what I'm talking about are different transfusion strategies you can use in massive bleeding. There are a lot of papers published about the one-to-one-to-one concept, which is very easy to do because you don't have to measure anything. Just if the patient is bleeding, you try to substitute a blood product. But the point is that you cannot do it in a targeted way. You can also use conventional lab results. The main problem is that it mainly takes too long time to get these results, to use them as a basic for your individual decisions. And what we more and more do during the last 10 years is an individualized point of care driven concept. So here's just one example for the one-to-one-to-one concept. It's published from Gonzalez, Big Trauma Center, and published in the Journal of Trauma in 2007. And I just want to focus on one number, that if you use the one-to-one-to-one concept in this study, they need in mean 14.8 hours to come to a targeted level of the INR. So it takes a very long time to correct the coagulopathy in the patients using the one-to-one-to-one concept. So what they conclude in their study was that you should be more aggressive in the pre-ICU intervention to correct the coagulopathy. In my mind, aggressive should be not the right word, because that may mean that you also accept to induce thromboembolic events. I think it's also important to avoid thromboembolic events. But the second point is that they say you should develop standardized protocols, and I completely agree. And we also developed algorithms for different settings like trauma, like liver transplantation and cardiac surgery, which we use to guide our therapy in these different clinical settings. So what we know is that blood transfusion is not always beneficial for our patients. There are quite a lot of publications which show that blood transfusion may also harm our patients and increase morbidity and mortality. And in this systemic review from Marek, we can see that in all published studies, the risk of infections increases significantly by blood transfusion. And here we're not talking about viral transmission. We are talking about nosocomial infections, which are significantly increased in all these studies. And that is not only true for red blood cells, it's also true for fresh frozen plasma. In this study from Zarani, published in Critical Care in 2008, they could show that if there is no fresh frozen plasma transfusion, the incidence of nosocomial infection was about 6%, and in patients with fresh frozen plasma transfusion, it increased threefold to an incidence of 18%. So that is one risk which is common for all the blood products. When we look at another problem of respiratory distress syndrome, also nearly all studies show that if you give transfusions to your patient, you have an increased risk of pulmonary complications. And I always are talking about one study, that is the study with the lowest impact to show these results. But when you look at the study of Khan, published in Chest 2007, you see that for all blood products, there is a dose-dependent effect in induction of pulmonary complications for red blood cells, for fresh frozen plasma, and for platelets. And for the fresh frozen plasma, it's already significant from more than 4 units of fresh frozen plasma. So this small amount is not sufficient to get any hemostatic effect, but it already induces pulmonary complication with an odds ratio of 3 if you give more than 4 units of fresh frozen plasma. What we know is that if you want to have any hemostatic effect of fresh frozen plasma, you need a high volume. So in this study, it was shown that if you use 10 milliliters per kilogram body weight, you are not able to correct the INR. You have to give at least 15 to 17 milliliters per kilogram body weight. Then in 1/3 of the patients, you are able to correct a pathological INR. But at the same time, you have a new onset of acute lung injury, which increased from 4 to 18%. So again, you have a high risk of pulmonary complications if you give fresh frozen plasma in a volume which is able to correct the coagulopathy. So in this study published by Dara, they come to the conclusion that the risk-benefit ratio for fresh frozen plasma may not be favorable. Yeah. Thank you. So a second problem, when we especially talk about the situation in liver transplantation, there is one publication in 1997 from a Japanese group which could show that if you give a high volume of fresh frozen plasma during living donor liver transplantation, you have a high rate of hepatic arterial thrombosis, which may be a result of an overflow over the portal vein, which compromise the perfusion over the hepatic arteria. So also in this situation, a high volume of fresh frozen plasma may be harmful for the patient. Another point is that if you want to use the one-to-one-to-one concept, you have to start very early by giving fresh frozen plasma. So in several centers, especially in the US, they work with pre-thawed plasma and start with ABO compatible but not identical plasma, which means you give all the patients AB plasma. But looking at these data published from one American group last year, they could show that if you give ABO compatible plasma but not identical plasma, and you give more than 6 units to your patient, you have the incidence of pulmonary complication and sepsis of up to 70% of the patients. And a group from Sweden, from the Karolinska Institute in Stockholm, looked at the same situation in more than 80,000 Swedish patients, and they could show the same effect if you give more than 5 units ABO compatible but non-identical plasma. You do not have only increase in morbidity, you have also increased mortality by 15%. So that, in my mind, means that it's not a very good idea to use ABO compatible but not identical plasma. So if you use plasma, it should be ABO identical, or what we do more and more, use factor concentrates and completely avoid the use of fresh frozen plasma. So the hardest endpoint is the risk of death, and you see here also that nearly all studies show that patients with blood transfusion had a worse outcome compared to patients who don't need any blood transfusion. And when we look again, special in the situation for liver transplantation, the group from Groningen could show in nearly about 450 patients that the blood product with the highest impact on mortality is the transfusion of platelet concentrates during liver transplantation, and independently of the transfusion amount for red blood cells, and also independent from the platelet count, they could show that if you have the need for platelet transfusion during liver transplantation, you have an 18% higher mortality, 1-year mortality of the patient. That is one reason we more and more try to avoid platelet transfusion during liver transplantation, which in our center is now in an area of about 20% of the patients, and we compensate more and more by going to a higher fibrinogen level. So we can summarize this part that we should be aware that blood transfusion is also dangerous for our patients. So we should think about each blood transfusion if it's good for the patient or maybe more harmful for the patient, and be more and more restrictive in blood transfusion. So the main question is, how can we stop the bleeding as quick as possible? So the question in this situation is, why does the patient bleed? So on the left side, it's very easy. I always say when the blood comes up to the face of the surgeon, it must be a surgical bleeding from a vessel with a high pressure. But that is not the main problem. The main problem is when we have a blood on floor syndrome. So then we have normally a combination of a diffuse bleeding and also surgical bleeding. And then it's not good for the patient to discuss if it's a surgical or a hemostatic problem. We have to work close together to solve these problems. So in the liver cirrhotic patient, which is the main group for liver transplant, we have a very complex situation even from the beginning. So we have some coagulation factors which are a very low level. Normally we have a low platelet count. We have a deficiency of vitamin K dependent factors, but also a deficiency of the vitamin K dependent antagonists, protein C and protein S. Also plasminogen is low and alpha-2 antiplasmin is low. But on the other hand, we have patients with bacterial infections, so there's lipopolysaccharides in the circulation. We have sometimes cells which express tissue factor because of infection or also because of malignancies. We have a high level of von Willebrand factor and factor VIII because that is not produced in the liver, it's produced in the endothelium and it goes in a compensatory way up. And we have high levels of TPA and plasmin activator inhibitor. So we have a low level of balance, and this level can go to bleeding and also to thrombosis in the same patient. So that is more complicated than in other patients. The point is, when we in Germany send blood to the lab, it normally takes about 30 to 60 minutes to get the results back. And that is, in the bleeding situations, much too long time to wait for these results and then do our decisions. The colleagues from France did it in a prospective randomized study. They compared a point-of-care device that was not a ROTEM, that was a coagulocek to measure the PT, and at the same time they sent blood to the lab. And you see that the point-of-care testing was much quicker, it was 5 minutes. And the median turnaround time from a lab was nearly 1.5 hours. So that's a very long time, longer than we normally have in our central lab. But it just shows that you cannot wait for these results to do your decisions. So one major rule, I think, in the bleeding patients is that you should not be slowly. So that's the way we use point-of-care devices. So that is in our cardiac OR. And we have, when we have a bleeding situations, we take the ROTEM, and on the left point is a multiplate for platelet function analysis just with us in the OR, so we don't have any ways to go, and we can get our results within about 10 to 15 minutes. With the ROTEM device, we have 4 channels. So the difference to the conventional tech is that most of the tests are activated by the extrinsic pathway, and we learned during the last years that that is the normal way of activation of coagulation in nature, that tissue factor is the main activator, which is used in the extrinsically activated test, in the FIB-10 test, and in the ABTEM test. So we get an idea with the XTEM test of the overall coagulation capacity. We also see with the clotting time if there is a need for vitamin K dependent factors. In the FIB-10 tests, we block the platelet function, so we only see the fibrin clot, and by comparing both tests, the XTEM test and the FIB-10 test, we get information if it's more a problem of fibrin polymerization or of the platelets. With the ABTEM test, we have the possibility to see if an antifibrinolytic will be able to stop hyperfibrinolysis. We also have intrinsically activated tests without and with heparinase inside, so that's the ABTEM test. You can also use, in principle, an heparin-based test, which is helpful if you work with direct thrombin inhibitors. And what is not commercial available, what we do sometimes in our hospital, is that if we think about the use of a special coagulation factor like factor 13, factor 8, factor 7A, we spike the ROTEM with these factors. So we just look in ROTEM if it will solve the problem, and we only use it in the patient if we see that it works. So that is cost saving for our hospital. We have several parameters which are close to the parameters of the conventional tech. So we see the coagulation time, which corresponds to the R time, which tells us how long does it take until the coagulation starts. But by using the extrinsically activated test, we get information about the vitamin K dependent factors. Then the most important parameter in my mind is the maximum amplitude, or for the ROTEM, the maximum clot firmness, but it takes about 20 to 25 minutes to get this time. So we more and more working with the amplitude about 10 or even about after 5 minutes to do our decisions. And we presented last year at the ASA these results. So you can see by using the extem A10 value, the amplitude after 10 minutes, the correlation coefficient is about 0.94. So we have already a very good correlation after 10 minutes. And even after 5 minutes, it's a correlation about 0.9. So we can do our decisions very early, after 5 to 10 minutes, what is the right thing to do in the patient. And what for me is the most important thing, that is not only true in the normal range. You see here that even in patients with a very low maximum clot stability and in patients with a very high clot stability, it's over the whole range, it's a linear correlation. And that is also true for the FIB10 test, where we block the platelet function. The A10 value have a correlation coefficient to the maximum clot firmness of 0.97, and already for the A5 value is 0.95. So the correlation is very good, and we can do our decisions very early. And here again, you see it's over a whole range. It's from a maximum clot firmness of 5 millimeters to 60 millimeters that you can do your interpretations. So if we use the A10 value, we know we have to add 3 millimeters to come to the maximum clot firmness. And if we use the A5 value, we have to add 4 millimeters. So that is very, very easy and very quick. So the main principle we use for the coagulation management is a pyramid of therapy. Of course, the basis is surgical blood stenching. Then we look at the basic conditions, because we know that hypothermia, acidosis, hypocalcemia have a big impact on the coagulation system. Then we think about pre-existing problems, as the patient is on aspirin, clopidogrel, oral anticoagulants, or heparin. Then we think about hyperfibrinolysis, then about delusional coagulopathy, where we know that fibrinogen is the most important factor. Then about the need for enzymatic factors, for which we use mainly PCC, proton-beam complex concentrate. There's a difference between Europe and US, because in Europe we use 4-factor PCCs, which include factor 2, factor 7, factor 9, and factor 10. And US normally, if you use PCC, have a 3-factor PCC with very low levels of factor 7. So that may be a difference. Then we think about platelets, and in the end we think about recombinant factor 7A, which we had not used over the last 10 years because there was no need for off-label use for factor 7A within the last 1,200 liver transplants and within the last 20,000 cardiac procedures. So that is one of our algorithms for liver transplant. So when we have a bleeding problem, we go through these algorithms so we can do a decision if there is a need for tranexamic acid. We have to correct the preconditions to give fibrinogen, or in this situation today in US you would have to use cryoprecipitate and platelets, ECC or fresh frozen plasma. Then we also look at the platelet function, and in the end there's a question if we need special factor concentrates like factor 13 or factor 7A. So when we think about giving an antifibrinolytic drug, we have also contraindications. So that is one example. It's a patient with Budd-Chiari syndrome, and you see that is in a hypercoagulative state. There's a maximum clot firmness for more than 80 millimeters, so that is for us a clear contraindication to give any antifibrinolytic. What we do in liver transplants is that we only give antifibrinolytics when we detect an hyperfibrinolysis, and even in this situation we know that 1/3 of the hyperfibrinolysis is self-limiting, that we don't have to do any therapy. So have a hypercoagulated patient, for us it's a contraindication against tranexamic acids. That is a clear indication. I think there's a fulminant hyperfibrinolysis. So we see within 15 minutes that there is a breakdown of the clot and at the same time a complete defibrillation of the patient. So what we do in this situation to give 2 grams of tranexamic acid and 4 grams of fibrinogen concentrate. We can do this very quickly. It's only a volume of 200 milliliters, so it's not a big problem, and also it doesn't increase any volume overload. That is a self-limiting hyperthrombolysis. So when we see, for example, here at the end of the aneuploidy phase of hydrolysis, but there is still a good clot stability and not a diffuse bleeding, then we just start the next test, and then we see over the time that the hydrolysis starts later and later, and in the end it's self-limiting, so we don't have to do a therapy when there is no clinical situation where we have to stop a clinical bleeding. That is an example from cardiac surgery. At the end of the cardiopulmonary bypass and after giving protamine, we had a diffuse bleeding, and what you see in the left side, that is the ROTEM analysis at this time, that you see even within 5 minutes that the maximum clot firmness in the FIB-10 test, where we block the platelet function, the clot stability is very low, it's only 4 millimeters. We know that when it's below 8 millimeters, you have a high risk of bleeding in cardiac surgery patients. All the other parameters are okay. So we know we want to increase the clot stability in the FIB-10 test. We can calculate this very well because we know if we want to have an increase in 8 millimeters, that's the target, to come to 10 to 12 millimeters in the bleeding patient, we have to give 50 milligrams per kilogram fibrinogen. So in the 80 kilogram patient, that is 4 grams of fibrinogen, which means 200 milliliters. To get the same effect with fresh frozen plasma, you need 3 liters of plasma to get the same increase in fibrinogen, but then you have a problem with volume overload, and at the same time, when at this situation the hemoglobin level is 9 and you give a lot of plasma, the hemoglobin level goes down, and then you have to give additional red blood cells without any bleeding, and you increase the volume overload. So that is one problem, and therefore we decided more and more to do our therapy with the factor concentrates. And when we look at the time with the ROTEM, it's possible within a little bit more than 30 minutes to do your diagnostic, to do the therapy and control of the therapy within a little bit more than half an hour, and you see we come exactly to the targeted area. So that's a table, our experience by using the fibrinogen concentrate. So if we know, or if we target an increase of 4 millimeters, we need 25 milligrams per kilogram, for 8 millimeters, 50, and so on. And on the bottom, there's a formula from Niels Meyer, is working in Hanover. So with comparing the formula to the table, it's just a difference in 8%. So the experience in Essen and Hanover are quite the same by using the factor concentrates. The problem is that up to now, fibrinogen concentrate in the US is only licensed for hereditary deficiency. I hope it's also licensed in the near future for the acquired bleeding situation, because that is a much bigger population of patients who need fibrinogen. So together with Ken Tanaka from Atlanta, we calculated the effects by using fresh frozen plasma, cryo, or fibrinogen concentrate. And the problem with fresh frozen plasma is if the fibrinogen level is very low, it's effective. But if you come to a range of 100, 150 milligrams per kilogram, you need more and more fresh frozen plasma to get a further increase, because there's nearly no concentration difference between the plasma of the patient and the plasma you give to the patient. So with cryoprecipitate, which has a fibrinogen concentration about 8 to 10 grams per liter, or with the concentrate, which has a concentration of 20 grams per liter, it's much easier, and it's nearly a linear correlation between the dose you give to the patient and the increase you get in the plasma of the patient. One other point is that fibrinogen is not only important for the plasmatic coagulation, fibrinogen also plays a very important role in platelet aggregation, because fibrinogen is the ligand between the GP2B3A receptors, which are important for cross-linking the platelets during platelet aggregation. So if there is no fibrinogen or very low level of fibrinogen, also the platelets cannot work. And that is the point where we learn that especially in patients with platelet dysfunction, we can compensate by going to a higher fibrinogen level. And that we use more and more during the last years, especially in liver transplantation, where we accept platelets of 20 to 30,000. We go to a higher level of fibrinogen, then we can avoid platelet transfusion. And also in cardiac surgery, where we have more and more patients on dual antiplatelet therapy, we can avoid platelet transfusion by going to higher fibrinogen levels. So that is one example with thrombocytopenia. So here it's only 4,000 platelets per microliter. So when you look at the extrinsically activated test, the XTEM and FIBTEM test, it nearly looks the same because there are nearly no platelets. But it's a non-bleeding patient because he can compensate with a higher fibrinogen level. But because this patient has preoperative values, we planned a big abdominal surgery. We give 1 unit of platelet concentrates. We come to a platelet count of 22,000 per microliter. But you see that the clot stability is nearly normal because it's compensated by a higher fibrinogen level. And we have no bleeding problems during surgery despite this low platelet count. On the other hand, you see that to have a high platelet count doesn't tell you a lot, because here you see it's 266,000 platelets per microliter, but these platelets cannot even be activated by thrombin. So you have a bleeding situations with petechia, hematoma, mucosal bleeding. So this patient needs platelets despite a high platelet count. So to have only the platelet count doesn't give us a lot of information. To have information about the platelet function, I think it has a much higher value in this situation. What we also can see is if there is a prolongation of the clotting time, like in this situation, if it's really affected deficiency or it's only a heparin effect. So that is an infant with liver transplantation just after reperfusion of a liver graft, and we see when we do the same test with heparinase inside, this is blocked. This is just a liberation of heparinoids from the liver graft, so there is no need for fresh frozen plasma and also no need for factor concentrates in this situation. That's completely different in this patient. So when we look at the left side, it's the ROTEM test at the bleeding situations. We see when we look at the FIBTEM, there is a maximum clot volumes of 12, so there's no need for fibrinogen. But when we look at the extrinsically activated test, the clotting time is longer than 80 seconds, and then we know that there is a problem with thrombin generation based on a deficiency of vitamin K dependent factors. So what we also can do with the ACT, or we also have cuvettes for the ACT device where we can measure the INR or the quick value. So we can then calculate the dosage for PCC, for proton beam complex concentrate. So if we want to have an increase in 25% of the activity, we give 25 units per kilogram body weight. That means 2,000 units of PCC. And for the same effect, we would have to give 12 units of fresh frozen plasma, which is a high volume and not so good for the patient in this situation. So what we see here, when we look at the conventional lab results, the INR comes exactly to the targeted area of 1.5, and the quick value is the percentage of activity from 25 to 50%. And also in ROTEM, we come to a level of a clotting time of below 80 seconds, so here 60 seconds, and all the procedure also within half an hour. We work with PCC over a long time, so that is the first publication from our center with PCC. It's from 1994. So these factor concentrates, fibrinogen concentrate and PCC, are licensed in Germany for about 20 years. So we have a lot of experience in managing these bleeding situations with the factor concentrates. What you, I think, more used when there are problems with thrombin generation in your patient is recombinant factor 7A. That is from one study which has been done in the liver transplant population. So what they could show in this study, that by using factor 7A, they were able to do 10% of the patients without any blood transfusion. We normally do 33% of our patients without any blood transfusion. But at the same time, there was an increase in thromboembolic events up to 19%. And I will present at the end of the lecture our results in the cardiac surgery, where we could show that we could reduce the thromboembolic events by 50% by our approach. What we sometimes also looking for is a deficiency of factor 13. That's not so easy to detect in the ROTEM too. What we see in some patients is that we have a slight clot instability over the first hour. You normally call it a hyperthrombolysis when more than 15% of the overall clot stability is reduced within 1 hour. You see here that it's 14%. But when you look at the test with aproteinin inside, it's also 10%. And then we sometimes spike the ROTEM with factor 13. You see then it's only 4% lysis over 1 hour. This shows us that there is a deficiency of factor 13, which results in a not so good cross-linking of the clot, and also factor 13 is responsible for incorporating alpha-2 antiplasmin into the clot, which makes the clot more resistant against fibrinolysis. So we use this spiking to do our decision, and then we only give factor 13 to the patient if it works within the ROTEM system. To show you the dynamic of a bleeding situation, that's just one example of postpartum hemorrhage, which very often is also a very, very severe bleeding and a high dynamic. So at the beginning of the bleeding, we here only use the XTEM test and the FibTEM test. You see that already the maximum clot firmness in the FibTEM test is relatively low. It's only 6 millimeters. That is below the normal range. But we know that at the end of pregnancy, the normal value of fibrinogen is double as high than the normal population. So it's between 4 to 6 grams per liter. And we know from a study in France that if at the beginning of a postpartum hemorrhage, the fibrinogen level is below 2, the incidence of massive transfusion is 100%. If it's higher than 5, it's 0%. So it's very dependent on the fibrinogen level. So that is just at the start of the bleeding. And then about 1 hour later, we did the second test. And when you think that you send blood to the central lab, it may need about 1 hour to get the results back. And that time, we would get results on the first blood sample to the URR at the second blood sample we take. But you see that the situation changed completely. We have a fulminant hyperfibrinolysis, so within 20 minutes, the clot breaks down completely. We have also a complete defusionation of the patient, so there's no fibrinogen left. So we can do our decisions very quickly. And in this case, we first give 2 grams of tranexamic acid and 4 grams of fibrinogen. So we did the detection 20 minutes after starting the test, and we already control our therapy 8 minutes after detection, because we can act with the factor concentrates within some minutes, and then we look what was the effect. So we stop the hyperfibrinolysis. There's fibrinogen back again, but there is an ongoing bleeding, and we see that the clotting time is borderline. It's nearly 80 seconds, so we need more thrombin generation. We also see that the overall clot stability is too low, so we also need platelets. And in the situation of a postpartum hemorrhage, 9 millimeters in the FibTEM is too low for us, so we also give additional fibrinogen. So the second step is to give 3,000 units of prothrombin complex concentrates, 1 pooled platelet concentrate, and another 4 grams of fibrinogen. And so you see that's 41 minutes later, the clot stability is restored, the bleeding is stopped, and overall we had to give to this patient 6 units of red blood cells, no fresh frozen plasma. When you compare it to the time within the 1:1:1 concept, with 14.8 hours, we need 69 minutes from a complete deterioration of the clot coagulation system until we stop the bleeding and restore the coagulation system. So when you compare the possibility by using factor concentrates on a goal-directed way based on the results of the ROTEM system against fresh frozen plasma, with the factor concentrates we are much more rapid, effective. We can calculate the effect and the dose we need. We can do it in a small volume, so we have never problems with transfusion-associated circulatory overload. We had no risk of TRALI because there have never been published any case of transfusion-associated lung injury by using the factor concentrates, and we have no risk of mistransfusion. And this, I would summarize also ABO compatible but not identical plasma transfusion. And these factor concentrates have a very effective viral inactivation or elimination. So even in the English-spoken countries, that's from UK, more and more centers say that it may be the future to change from fresh frozen plasma to factor concentrates to do a more effective therapy. But for us in Germany, this future is now, so we already use this during the last 10 years. That's our experience in the liver transplants over the last 10 years. So you see the red line is the need for red blood cells, not only for the liver transplant, that is for the whole visceral surgery. So you see that we have a reduction in red blood cells by 60%, a reduction for fresh frozen plasma by nearly 90%, and also a reduction for platelets by about 60%, and at the same time, an increase in the liver transplants by nearly 50%. So, and over the whole time, no off-label use of factor 7A. Of course, we have an increase in the factor concentrates. The blue line is the need for fibrinogen concentrate. And in 2004, I had one telephone call from our pharmacy that I would ruin our hospital with the use of factor concentrates. But when they looked at the transfusion requirements, they could see that we have a 20% reduction of the cost and not an increase in cost because we have less and less blood products to transfuse. So in the end, in the last year, we did about 162 liver transplants, and only 65% we had to give any red blood cells. The median number of red blood cells in liver transplants are 2 units. 80% of the liver transplant we can do without any platelet concentrates, and 83% without any fresh frozen plasma. Cryo is not in use in Germany, and we had no case of off-label use with factor 7A. So when we look over the last 10 years, only for liver transplant and visceral surgery, it was in the end a cost saving of €1,700,000 for our hospital to change from more fresh frozen plasma-based therapy to the therapy with factor concentrates. The problem is that the cost for blood products and also for factor concentrate are very different from country to country. So you have to calculate from your own costs you have in your country if that results in a cost saving or not. That are data from cardiac surgery. They're just 1 week online in anesthesiology and will be published in a print version in December. That our experience over the last 5 years in cardiac surgery. That's the algorithm we use in cardiac surgery. It starts with the test of a platelet function with a multiplate. When we have patients with dual antiplatelet therapy, we think about the need for tranexamic acid. Then before weaning from bypass, we look at the preconditions. When we have a bleeding patient, then the main algorithm starts, because it's very important that we don't treat numbers. We don't give any intervention when we only have pathological values in the ROTEM. The main and first question is there is diffuse bleeding or not. If there is a diffuse bleeding, the ROTEM can help us to do this right decision, what's the best way to stop the bleeding. Then you think about redosage of protamine, of fibrinogen, of PCC, of fresh frozen plasma, of platelets, and in the end, factor 13 or factor 7A. Within the study, we compared the patients from the year before we implemented ROTEM in 2004, that are 1,718 patients, and then after implementing ROTEM and multiplate, developing our algorithms and the refinement of our algorithms, we compared with the patient in 2009 as a 2,147 patients. So there are 25% more patients in the ROTEM group than in the non-ROTEM group. So in the end, we only do point-of-care testing in cardiac surgery when we have a diffuse bleeding, or then if we have patients with a high risk of diffuse bleeding. So the patient population is not really comparable because in the ROTEM group, the mean age of the patient is much higher. There are more female patients in the 2009 group, which have a higher risk of bleeding. We have a higher incidence of patients on warfarin. We have a 5 times higher incidence of dual antiplatelet therapy, which should increase bleedings too. We have more emergency procedures, less elective procedures, a higher number of procedures, and more complex than normal cardiac surgery. So overall, the population in 2009 has a higher risk of bleeding than the population in 2004. That are the results that we were able, despite this change in the patient population, that in 2009, with using the ROTEM, that are the blue bars, we have 10% less transfusion of any allogenic blood products. We have a 10% less incidence of red blood cell transfusion. For fresh frozen plasma, we come from about 19%, and now it's 1.1% of all patients in cardiac surgery who get fresh frozen plasma, and a slight increase in the platelets. Then at the bottom line on the left side, that's the overall need for blood products, and you have to keep in mind that in the blue bars, it's 25% more patients than in red bars. Despite this, there was a reduction in overall transfusion requirements, but when you look at the right side, of course, there is an increase in the use of fibrinogen concentrate and PCC. So the main point is that we were at the same time able to reduce the incidence of massive transfusion by 1/2, from 2.5 to 1.2%. Also, the incidence of resurgery from 4.2 to 2.2, and the incidence of any thromboembolic events, including stroke and myocardial infarction, from 3.2 to 1.8%. So it's not only more effective, it seems to be also more safe for the patient to do a targeted therapy compared to the intervention we did before. And one point for this is that we know you can also use the ROTEM to predict the risk of thromboembolic events. When the clotting time is very short or the maximum clot firmness is very high, we have increased risk of thromboembolic events. And when we monitor this, we were able to do a targeted therapy that we avoid over therapy in our patients. So that is, for example, a patient with recurrent thromboembolic events. And when you look at the conventional lab tests, it's a patient on warfarin and heparin. So the INR is 3.5 and PTT is higher than 60 seconds. So would say, okay, that's just in the targeted area. But this patient has a daily incidence of thromboembolic events. And when you look at the ROTEM, you would say that it can be predicted because the clotting time is very short and the overall maximum clot stability is very high. And we can only see this in the ROTEM because from the clotting time, the point of the clotting time, we see tissue factor expression on circulating cells with the ROTEM. And that's not possible with the conventional test because first you eliminate all cells and then you do the measurements in the plasma. So when we look at the cost, we could also show that by using this new technique, we had a cost reduction of 50,000 euro per year. It's not a very high amount, but it shows that even if you do a better and more safe therapy, it must not be more expensive. It can also save money for your hospital. So that are the conclusions from anesthesiology, that we know that allogenic blood transfusion increases morbidity and mortality, but when you use coagulation management based on algorithms, based on a first-line therapy with coagulation factor concentrates, which are guided by a ROTEM test, you are able to reduce the transfusion requirements and at the same time reduce the incidence of thromboembolic events. And so that is my final conclusion, that the treatment of bleeding is to stop the bleeding. 1 month ago I was in Australia and we talked about massive transfusion protocols, and as I said, we don't have any massive transfusion protocol. We have a massive transfusion avoiding protocol because we want to stop the bleeding before you come to the area of massive transfusion. So I think at the same time you should avoid thromboembolic events. Another target is to reduce transfusion requirements and of course transfusion related adverse events, and the main target is to save patients' life and to reduce the cost for the hospital. And thank you for attention.
Matter. Is that it?
So I'm open for questions.
If you're joining us via telephone, please mute your phones. Thank you.
Yes.
We're now accepting questions.
We mainly use imperative setting pool platelet concentrates because we have also a big unit for bone marrow transplantation. So the most of the apheresis platelet concentrates goes to the oncology and the bone marrow transplantation. So for the imperative setting, we mainly use pool platelet concentrates. It's 4 to 5 per pool, yeah. But the point for the platelet concentrate is, there was a study in Germany, I think 2 years ago. You have a relatively high rate of bacterial contamination. It is about 0.15%, so it's much higher than any viral contamination because you cannot cool the product. And that was the reason in Germany the allowed storage time was reduced from 5 to 4 days. And at the same time, when you look at the platelet function of the oldest platelet concentrate, the function is very low, but the risk of bacterial contamination is very high. And that is also one reason we try, if possible, to avoid platelet transfusion in cardiac and also in liver transplant. We're more liberal in the trauma situation. But especially for the cardiac, if we have a patient on a dual antiplatelet therapy, and we know if we stop it, we have a high risk of stent thrombosis, I think it's also not so reasonable to give a lot of platelets, because then you have the same risk that the platelets you transfuse may increase the risk of stent thrombosis. And we learn that we more and more can compensate this by higher levels of fibrinogen. But then we have to target levels of about 2 to 3 grams fibrinogen in the plasma of a patient, which is not possible to get with fresh frozen plasma. You have to use cryo or fibrinogen concentrate to reach this level. Yes, all our blood products since I think 5 years is only allowed to use leukocyte-reduced blood products in Germany. Sorry? The testing with the multiplate, or yeah, in the blood bank they don't use the multiplate for testing. We only do this in a clinical situation, because the point is that in the situation of the platelets within the bag, you have a reduced function, and that is it's planned. So the platelets also need some time in the patient to restore the platelet function. But we see that you have a decreased activity with a longer storage time of the platelets. And we know from the red blood cells too that a long storage time is not so good for the red blood cells too. You have reduced oxygen delivery to the tissue. The deformation of the red blood cells are reduced, so you have a microemboli by giving very old red blood cells. So I think for both the platelets and for the red blood cells, the storage time is very important for the efficiency and also for risk of these products.
Hear me? Is it Gorlinger?
Did it?
I've got a question.
When we compare the apheresis to the pool, yes, I think there are some data that the apheresis have lower risks. You have only from one patient the platelets. That's the reason why we give to the oncologic patients where we want to avoid a sensibilization against the platelets. We always give the apheresis. We would be lucky if we can give to all the patients apheresis, but that is up to now not possible, but our blood bank are working on this problem. So they say they don't have to spend a lot of time to produce fresh frozen plasma. They use this time to produce more apheresis platelet concentrates. I think that's the better way. Yeah. That they have better results with pools. Yeah, that may be one point. Yeah.
Hi, we have a question. We have a question from David Paul. He wants to know what dose of antithrombolytic do you use in liver transplant when indicated?
Antithrombolytic. Yeah. The point is, some years before, when we give PCC, a protein complex concentrate, we combined it with antithrombin. But we have seen that there is no need for it, because in the PCC, there are very high amounts of protein C and protein S. So that is the main antithrombotic part which we use in this setting. Because we know that especially in liver transplant, there's not so a problem with the antithrombin, but the vitamin K dependent antagonists, the protein C and protein S, are very low. So if we use the PCC, we keep the balance between the activators and the antagonists. So in the bleeding situations, we now completely avoid to give antithrombin. We did this before, but especially also in the cardiac setting, we had a pilot study where we used in one group PCC combined with antithrombin, and in the other group a targeted therapy based on ROTEM without any antithrombin, and all thromboembolic events were in the non-targeted group despite the use of antithrombin. So I think it's better to do a targeted therapy than just to add antithrombin, because we know when there are small amounts of heparin, you have problems with increased bleeding by adding antithrombin. So we don't use it in the bleeding situation. We don't use always all four tests. So in my opinion, you should first have the question, and in most of the cases, for example, you can say, I look for the XTEM test and the FIBTEM test. The INTEM and HEPTEM is only necessary if you want to see any heparin effects, or a deficiency of intrinsic factors. We know that at the beginning, and if you have a trauma or a big surgery, for example, factor VIII and von Willebrand factor goes high very quickly because it's liberated from the endothelium. For example, at the end of a cardiac surgery, the factor VIII level is about 130 to 150% compared to normal. So there is no need for factor VIII. But when we have a very prolonged bleeding or a very long surgery, maybe factor VIII goes down. And then we see that if we give PCC, we can shorten the clotting time in the extrinsic test, but we get a more and more prolongation in the intrinsic test. Then sometimes we spike with factor VIII, and if factor VIII solves the problems, we just give factor VIII, or in this situation, we give fresh frozen plasma if we don't really know if it's factor VIII or factor V or factor XI missing, if all these factors are not in the factor concentrates. Then we can increase the level of these factors by giving fresh frozen plasma. But then we don't need such a high amount of FFP, because if you reach a level of 20 to 25% of these factors, that is enough, and all the other factors are in a level which is high enough. So I think in the bleeding situation, fibrinogen and prothrombin are the most important points, because you need fibrinogen as a substrate, and you need prothrombin to increase the thrombin level. So if these two are on a good level, the other enzymatic factors, you don't have a need that they are normalized, and they are 20 to 30%, that's enough. Sometimes factor 13 is also a problem, but normally not in the primary surgery. It's more a problem 2 to 3 days later, because that's this long half-life time, but also a very slow production. So sometimes it goes down during the first days at the ICU, and then you may have a rebleeding, and that may be caused by a deficiency of factor 13. Yeah.
Gorlinger, can you hear us?
Hi, can you all hear me?
Yeah.
All right. The University of New Mexico has a question. They say the ROTEM is relatively new in the USA, and much of the experience is with the TEG. Why should I choose the ROTEM over the TEG?
I think there are some differences. One difference is if you want to use the device in a mobile way, the ROTEM is much less sensitive against agitation. So if you use the TEG mobile, you have a lot of artifacts, and you don't really know it's an artifact or is it what you measure in the patient. So we can use the ROTEM without any problem in the mobile way. And there are also ROTEMs in Afghanistan. You can use it outside the hospital without any problem. The second point is that they are different tests, so we know that the natural way of activation of coagulation is by using tissue factor. The tests in the TEG are based on intrinsic activation, so that gives you no information over the vitamin K dependent factors. And also I know from the colleagues from UK that there is, I think, a misinterpretation by using the TEG when the maximum amplitude is low. Also, a lot of colleagues in UK first give platelets. So you cannot really do a decision if it's a fibrinogen deficiency or is the platelets problem. And by using the tests we have in the ROTEM, it's very easy to differentiate between these two problems.
Can you hear us, Dr. Gorlinger? Hello?
Yeah, if you ask us the question, we'll reiterate it.
I have no experience with the three-factor PCCs. The difference is first that they have very small amounts of factor 7. I think that is not a big problem for warfarin reversal, because in this situation, the need for factor 7 is not so high. But if you have ongoing bleeding, we know that also factor 7 goes down relatively quickly, especially the first and the second day after surgery. So maybe by using a 3-factor PCC, the risk of rebleeding after surgery may be higher. It's just a speculation because we don't use the 3-factor PCC. One second point is the companies who produce any PCC have to put in something to reduce thrombin generation. You can use heparin, you can use antithrombin, or you can use protein C and protein S. The products we use are mainly based on protein C and protein S, and that is the most physiological way. So if you have a PCC which is mainly based on heparin and antithrombin to reduce thrombin generation, that may have a higher risk of bleeding. So the group of PCCs are very different. And also what you have to think about, I had heard one lecture also, I think 2 years ago, and then they talked about PCC, but they talked about activated PCC. That's a completely different substance. So that is a substance which is only used for acquired hemophilia, like the main indication for recombinant factor 7A. So we never use activated factors in the perioperative bleeding situation.
I can't hear you over the music. I'm very, very sorry.
We don't really know. We were just discussing a study in Australia, and they have the same situation, that they have mainly the 3-factor PCC. And I think we have to look if that is really a problem or not. We know when you have a deficiency of the coagulation factors, nearly all coagulation factors are in a sufficient range for thrombin generation when you are in an area of 25%. The only enzymatic factor which has a linear correlation to thrombin generation is prothrombin. So I think that is the most important factor in the PCCs in the acquired bleeding situation. So I don't really know if it will be a big difference to use 3-factor versus 4-factor PCC in the acquired bleeding situation. I think we have to look in clinical studies if there is a really big difference.
I'm not ready.
Got a car? You want to go with me? I'll take Silver.
Yes.
Hello, this is the ROTEM conference. It sounds
I
like
think
the
so.
music is
I
over.
don't really know the cost for fibrinogen in US, but I think it was about for 4 grams. So it's about $700 for 1 gram.
That's good.
And, the cost for our hospital, it depends on the amount you buy. It's about 280 euro per gram. So it's cheaper than in US. Fresh frozen plasma is about 60 euros per unit. So our experience is that with each gram of fibrinogen, we reduce the requirements for fresh frozen plasma by 6 units. So when you compare this as a 280 euro against about 300 euro, so that is already a cost reduction, but the main cost reduction is to reduce or stop the bleeding much quicker. That is the main point. And one point too is that in our hospital we say if we do a targeted therapy, we completely avoid fresh frozen plasma. I know several centers also in Germany, they say, oh, we have a need for a special concentrate, but we give the fresh frozen plasma in addition, then you can reduce the cost. So one point is to do a decision to do it more as a specific way or the unspecific way. To do both at the same time cannot reduce costs.
Common question from surgeons, especially in the liver transplant arena, is a concern about thromboembolic events. What's the experience been with conventional therapy versus the therapy that algorithm you spoke of?
Yeah, I don't have the complete data for that because last year we focused on the cardiac patients, so we just start to analyze for the liver transplant patients. But also the impression from our surgeons is that we have less and less thromboembolic complications. And what is important is, and therefore we have different algorithms, the target, for example, for fibrinogen or the FibTem level for liver transplant is much lower than for cardiac surgery or for trauma. So for the liver transplant, in the most of the patients, enough to come to a maximum clot firmness in the FibTem of 8 to 10 millimeters. For cardiac surgery, we more go to 12 to 15 millimeters. And a big aortic surgery sometimes goes to 20 millimeters. And also for multiple trauma patients, especially when there's a pelvic fracture, we also go to very high levels of fibrinogen. So that depends on the situation. And the underlying point may be that especially the liver cirrhotic patients compensate over other factors like von Willebrand factor and factor VIII, which is very high in these patients. So to go to the same level in the cirrhotic patients compared to the others may not be a very good idea. Then you have increased risks of thromboembolic. And the other point, very important point, is that we only start the therapy if we have a bleeding problem. So if there is a FibTem of 6 without any bleeding, you won't give any therapy. Then maybe you increase the risk of thrombosis. Yeah, I know that in the recommendations for warfarin reversal in the US, you have to say you should give PCC, but maybe you have to add some fresh frozen plasma or recombinant factor 7A. There's just this year published one study in Australia by using a 3-factor PCC for warfarin reversal, not for the acquired bleeding situation. And for warfarin reversal, they could show that it's efficient to use the 3-factor PCC without factor 7A and FFP. But I think the situation may be different in the acquired bleeding situation because you have ongoing bleeding, you have a lot of factors which go down, so I think it's not the same like a warfarin patient. Okay.
Around the corner, mainsail.
Thank you.